Good morning, students. Good morning. Okay. Okay, it's all muted. And the series of lecture, I think we had initially introduction to pediatrics. And last time I was giving lecture on communication and counseling skill. So I think we have around another 10 lectures. Basically, it is a theoretical one. And today, Dr.Nani Tago will talk on history taking in pediatrics, and followed by general examination in pediatrics. Dr.Pepu Jini will talk on the topic. Hope in another few weeks we will try to cover it. I'm also planning to have live transmission of how to examine respiratory system CVS. We will try to do that. I don't know whether our network will allow all those things. So over to Nani Tago.
Good morning. Today I will be taking history taking in pediatrics. The very purpose of clinical practice is to relieve suffering of the child or the patient, those who come to us. And to achieve that, we need a diagnosis. And to have diagnosis, there are two main steps. First is to establish clinical features by history and clinical examination, which is called clinical database. And second step is to interpret that clinical database into abnormal function and positive pathologies, maybe mental, physical, social, and combination of these. So today I will be taking history taking. So we had the first session, which was taken by our HOD on communication. So communication skill is very important to extract history. So it is an opportunity. The history taking is an opportunity to understand patients' perception of their own problem, and then we should try to make or complete a diagnosis. So without any waiting, let's go to the next. First is the order of history taking. Number one is patient identification, chief complaints, history of present illness, history of past illness, contact history, allergic history, personal history, antenatal history, birth history, neonatal history, developmental history, immunization history, dietary history, family history, and socioeconomic history. So first is identification. So we should record the name, for it's mandatory for identification. Also, when we address the child or the patient by name, it gives security, it gives confidence. Number two is age of the patient. Age of the patient is also should be recorded. It gives a clue to diagnosis because certain diseases are prevalent in certain age groups. For example, acute lymphoblastic leukemia, more common in children less than 10 years. Acute rheumatic fever, more common in age group of 5 to 15 years. Nephrotic syndrome, 2 to 10 years. Similarly, we have congenital heart diseases which have varied age of presentation, like VSD. Presentation could be 4 to 6 weeks of age. ASD more in adults. And then congenital heart diseases which present as cyanosis at birth could be due to transposition of great vessels, tricuspid atresia, total anomalous pulmonary venous connection, truncus arteriosus, and tetralogy of Fallot. Sex, record sex. Some diseases are more prevalent in certain sex. For example, ASD and primary pulmonary hypertension more common in female sex. Similarly, severe acute malnutrition and child abuse more common in female sex. It is due to preferential nurturing of male child in certain sections of the society. Then we have the residence, place of residence and place of origin of the person. So residence, certain diseases are more prevalent in certain geography. For example, we can have the PDA in high altitudes, then endemic goiter more common in hilly terrain. Then we can have sickle cell diseases more common in hilly areas and tribal communities. Second is to record informant. Who is the informant? And we have to establish the relationship between the patient and the informant. The informant could be mother, could be parents, grandparents, uncle, aunts, or could be someone else. For example, teacher, the warden from school where the child is doing his schooling. Then reliability of the informant. Reliability of informant is very essential to establish the, to give value to the history which we are going to extract. So what is the, how close is the informant to the patient? What is the educational level? These are all necessary to be recorded. After identification of the patient, next is chief complaints. Chief complaints is are the complaint with which the parents or the child represent to us. It should be recorded in the informant or patient's own language, recorded in a chronological order of their appearance. Refrain from asking leading questions and should not rely on medical opinion by other medical profession to avoid undue waste. For example, if a parent come to us with a chief complaint of my child is suffering from typhoid fever, it should be recorded as plain fever for like 15 days. So chief complaints could be fever, cough, abdominal pain, diarrhea, vomiting. Followed by chief complaint is history of present illness. So history of present illness here in history of present illness, this is an opportunity to extract maximum information from the parents. Try to give and ask an open-ended questions so that they give a detailed account of each complaint. So detailed account of each complaint in order of their appearance. Leading questions can be asked. Ask appropriate questions to segregate relevant positive histories from negative histories of the illness. Medical terminologies can be used at this juncture to describe the history of present illness like convulsion, dyspnea, oliguria. So today we are not going we are giving the principles of history taking. History taking and clinical examination of each system will be dealt when we meet in our clinical sessions with the patient, with the case. So in the history present, we can ask from when the time child was normal, inquire about the first symptoms when appeared, and if the child was never been normal from birth, then we can start the history from perinatal events and neonatal period. So we should proceed in an orderly fashion to elicit a detailed symptom-wise and then a system-wise history. For admitted patients, course during the hospital stay should be included, and for patients seen by different physicians and treatment received from them must be recorded. So for example, if a child comes with fever, so you can ask leading questions like what is the duration, whether it is for short duration or it's a long duration, what is the onset, whether it is abrupt onset, like it could be like pneumonia, UTIs or malaria, or it is of gradual onset like tuberculosis. What is the course of fever, whether it is continuous, whether it's intermittent, whether it is remittent, and then associated symptoms like whether it is chill and rigor, like in case of UTI, in case of pneumonia, or in case of follicular tonsillitis, or there is some altered sensorium or convulsions, then we might be dealing with some central nervous system. Also, if possible, if the parents have recorded the temperature, so recorded temperature can be recorded, can be noted. Then remission, how it is remission, abruptly it is remitted or it has remitted with some medication. Second chief complaint could be cough. We can ask for duration, whether it's productive, non-productive, diurnal variation, seasonal variation. What are the aggravating and relieving factors? If associated with sputum, whether what is the amount, what is the blood, what is the color, and what is the order of the sputum. Then we have pain. So pain, we can ask what is the duration of pain, onset, how it is onset, what is the character, frequency, severity, where is the site? Can the patient locate the site of pain using a single finger or it is using a palm, whether the pain is localized to the same site or it is radiating to some other place, and what are the relieving and aggravating factors, then and associated symptoms. Then we can have diarrhea and vomiting. So what is the duration of this diarrhea, for how many days, what is the amount, and what is the frequency, how many times the child passes stool, or how many times the child has vomited during the time. Then whether there is any blood in the vomitus or blood in the diarrhea, what is the color and what is the odor. So history of past illness. In history of past illness, we have to go for similar or related illness in the past. And if there is, we should record what is the, when was the onset, what was the treatment received, what is the course of illness, and what is the number of episodes and frequency of relapse. And if significant disease in the past, what is the duration, what is the response to treatment. For example, when we are dealing with like a cardiovascular system, for example, if the child had previous cyanotic spells, for example, we may deal with a case of rheumatic disease, rheumatic fever. So whether it is a recurrent, whether the child had similar episodes in the past. So for example, in case of CNS, central nervous system diseases. So like, for example, if the child had any convulsions previously, so this must be recorded in the history of past illness. In case of respiratory symptoms, like the child had any wheezing or recurrent respiratory tract infection previously, these all should be also recorded in the history of past illness. So treatment of history of past illness should include what are the prior hospitalization for similar or other illness with duration, what is the nature of treatment given, whether there was improvement or deterioration with the treatment, and what were the modes of modalities of treatment like radiation, surgery, blood transfusion, any drug allergy. This should be recorded in history of past illness. Then contact history. Coming to contact history, we can ask leading questions to inquire about recent occurrence of communicable disease in the family or in close contact. So when we are dealing with scabies, we can ask if any of the family members are also infected with the same, or if there is chickenpox in the family, if other siblings are also affected. Or we can ask for a history if there is any member in a family with recurrent cough with expectoration when you are suspecting tuberculosis. So next is the history of allergy. History of allergy to any food items and history to allergy to any medications should be recorded. Personal history here, like for example, in which class does the child goes and what is the school performance? Does the child take part in extracurricular activities? How is the child's interaction with friends and teachers? Does the child have any specific food habits? These all should be noted in personal history. Next is antenatal history. So in antenatal history, we try to extract the information about the events that have occurred during the intrauterine developmental period and that may have led to present illness. And this is especially important for children with congenital defect or disorder. We have to ask for appropriate leading question to discover all possible antenatal offending stimuli, like maternal disease or disorder, like maternal child, if the mother is suffering from diabetes, mother is suffering from hypertension or UTI, or lifestyle, mother's lifestyle, for example, whether the any smoking history, any alcohol history, or any drug intakes in mother, and also drug history in mother, like for example of like AEDs like phenobarbital or valproate, or like drugs like AC inhibitors if the mother is consuming. These are the components of antenatal history. We should record what is the age of the mother, what is the weight and height of the mother, immunization status of the mother, whether TT was received or whether rubella vaccination was taken, what is the gravity and parity, history of any abortion and stillbirth, any pregnancy interval, because multiple pregnancy without spacing, we may get small for gestational age, history of multiple pregnancies, history of complications like oliguria, polyhydramnios, then history of RH in ICU immunization, what was the diet during pregnancy, history of disease or infection like HIV, like torch, history of any drug intake, maternal lifestyle and habits, and maternal malnutrition. So we should record all these histories. Then we come next is birth history. What is the birth order and birth spacing? So if the birth order is like 4th, 5th with inadequate spacing, you have very likelihood to get a small for gestational age. Multiple pregnancies like twin pregnancy, triplet pregnancy, the second baby is more likely to suffer from hypoxia or hypoglycemia. Mode of delivery, what is the mode of delivery, whether it is normal vaginal delivery or lower cesarean section. What is the place of delivery, institutional delivery or home delivery. Person who conducted the delivery, whether it was a trained nurse, trained doctor, trained guys or untrained. What is the gestational age, whether it is term baby, post-term, preterm, and what is the birth weight, whether it is appropriate for age, small for gestational age or large for gestational age. Any complication like asphyxia, did that baby cry immediately after birth? If not, what were the resuscitations taken and what were the resuscitations given?
No, just wait. It's not there. Just wait.
Okay.
Okay.
Okay. There is a pause failure. We will start now.
Sir, so there was interruption due to power failure. We are resuming back. After birth history, we have the neonatal history. So neonatal history, it is the period after the birth of child up to 28 days of life. Here, there are certain issues which we have to try to take information from. Whether the child was exclusively breastfed or artificially fed, whether birth dose immunization given, were there any feeding problem and what is the duration of feeding, like there could be cracked nipple, there could be breast engorgement, and neonatal problems like there could be cleft because of which there were certain feeding problems. Then there could be neonatal problems like jaundice, RDS, convulsion, and if there is any history of hospitalization, duration and nature of treatment, and during this period whether there is appropriate weight gain or there is weight loss. This should be recorded. Next is developmental history. In developmental history, we have to ask appropriate developmental milestone questions. Record what are the milestones attained, and if there is any gross deviation, that should also be recorded. And if there is any history of any regression of milestones, that should be recorded. We have to we should emphasize that we should ask appropriate developmental or milestone questions. Followed this or developmental history, we have this immunization history. So immunization history, we have to take the immunization history, whether the child has received all the immunization, and if possible, we should try to get the immunization card and see for ourselves what are the immunization which has been received. And this is an immunization slide of immunization schedule which is followed in our state of Arunachal Pradesh. Then this is the IAP immunization schedule for 2019. Okay. Follow this, we have a dietary history. Dietary history should include the dietary pattern and habits of the child since birth. Also, diet taken in the 24 hours period immediately before the present illness should be recorded. calculate the expected calories and protein required, and then compare with the pre-illness treatment. And also you have to record if the child is a beneficiary of any meal schemes. Now, dietary history, for example, pre-lactal feeding details. We can ask what was the time interval between birth and the first feed? What was the first feed consist of? Was the colostrum fed or not? Were any pre-lactal feeds such as sugar water or honey given before breastfeeding? Details of breastfeeding. What was the breastfeed? When was the breastfeeding started? How long it was continued? Was exclusive breastfeeding given for the first 6 months or not? And if not breastfed, record the details. What was given to the child? What milk, cow milk or artificial? Whether it was any diluted, how it was given by bottle or palady, and how was the uptake by the baby. This all should be recorded in dietary history. Then details of complementary feeding, like when was the complementary feeding started? What was the type of food used for complementary feeding, like rice water, dal water, khichdi? What were the amount and frequency of complementary food? And when was the solid food started? And was the child given any vitamin supplements? In case of an older children, we have to look like what is the diet, whether it is a vegetarian or non-vegetarian. What is the amount and frequency of food intake in the last 24 hours with details of quantity and quality? And was the child given any vitamin supplements? And was the child a beneficiary of meal scheme? Now, this is a formula, holiday cycle formula for calculating the daily requirement of calories based on weight of the child. Less than 10 kilo, the daily requirement of calories is 100 kilocalorie per kg per day. Between 10 to 20 kilos, it is 1000 kilocalorie and 50 kilocalorie per kg per day. Above 10 kilo of weight, then if the child is weighing more than 20 kilo, 1500 kilocalorie plus 20 kilocalorie per kg per day above the weight of 20 kg. This is a summary of RD, recommended dietary allowance for Indians in 2010 by the ICMR. So this is a chart given where we have the groups, the age group, the weight, what is the probable weight, and what is the calorie requirement, protein requirement, fat, calcium, and iron requirements. Family history. Family history is important because family history has a strong bearing on disease propensity of an individual. Some diseases, they are genetic, and some communicable diseases, they spread faster within the family. So there are certain important aspects which we have to record, like what is the age of parents at marriage. Increasing age of mothers, then we are more likely to have Down syndrome, and in case of father, more likely to have Marfan syndrome. Then if there is a history of consanguinity, because autosomal recessive disorders, diseases, they are more likely to affect if there is a history of to a child born with a consanguineous marriage. Then we have to have a pedigree chart or family tree. It is a pictorial representation of family members with standard charts where all the family members, including parents, siblings, abortions, everything is given. And if there is any significant illness in the family members, for example, congenital heart diseases. If there is a congenital heart disease in a family member, there is more likely the other family members may be affected. Also, like seizure disorders and some contagious disorders with high secondary attack rates, they can also have more incidents in the family members, within the family members. And we should record the family history which is relevant to nutrition, like what is the parents' occupation, whether the mother is working or not, whether it is a nuclear family or it is a joint family, whether it is a broken family. This all should be recorded in a family history. So this is a chart of degree of consanguinity, the first degree, second degree, third degree, and fourth degree, examples and common genetic makeup. So this is the standard pedigree symbols used for pedigree chart. We have the individuals, affected individuals, we have to define by shading or some filling. And this is the pedigree relationship lines used in pedigree chart. Socioeconomic status. For socioeconomic status, we have to know the education of the parents. what level of education, whether they have completed primary, whether they have completed secondary education, whether they are graduate, what is the occupation of the parents, daily wages, or they are white collar, and what is the per capita income, of the family. That is the total income of the family with divided by the number of family members. We have the housing condition. What is the type of house they reside? Whether it is thatch, whether it is pakka, whether it is RCC. What is the living area of the person? Ventilation facilities are available or not? Water resource to house like well, tap, water, bore well, and water cleaning facilities like boiled, filtered, any other or none. And sewage disposal like sanitation facilities like toilet facilities, or whether they have open air defecation, and what is the hygienic status like distance from water source and washing status. We have a Kupu-Swami scale to determine the socioeconomic status based on education of the parents, occupation of the parents, and family income. And based on this, the socioeconomic status can be divided into upper middle, upper, lower, and lower. So this is the end of the schematics of history taking. However, history taking is an art which grows with knowledge and with experience, and it requires patient listening to the parents, be empathic with the parents, and at the end of the history taking, try to summarize all the concerns with the parents, and then try to get what are the ideas, what are the concerns, and what are the expectations of the parents with which they have come to us. So with this, I end here. Thank you.
Thank you, Nani, for the excellent presentation. Next, we will go to general examination by Dr.Pepu Jini. It will take 1 or 2 minutes. Just wait for a few minutes. We'll do the uploading and everything. Just wait for 2 minutes. So, dear students, see, most of the disease can be diagnosed by the history alone. Okay? Then comes the general examination, the necessary, and then the systematic examination, then conventional basic investigation, and the advanced investigation. So most of the 99% of the neurological diseases can be diagnosed by history alone. Okay. So the art of taking is very, very important by using your communication and counseling skill. Otherwise, the patient will not tell many history. Okay. So now I think we will have, when you come to our ward and other thing, we will have some more hands-on training on pedigree and case sheet writing and other thing. Now over to Pepu Jini to talk on general physical examination in children.
So good morning, everyone. After having taken the history, the next part is examination of the patient. So for examination of the patient, it is generally divided into 2 parts, which is the general physical examination and the focused systemic examination. So for physical examination, the first and the foremost thing is the child should be adequately exposed, should be properly seated or comforted in the mother's lap if it is a small child, so that you can examine the child properly from complete head to toe, and then the physical and the systemic examination. So now today we'll talk about the general physical examination. The systemic examination will be dealt with specifically in this when we talk about the specific systemic examination. So now we'll see the general physical examination in children. The sequence of examination as such, overall examination of a child as such, should be proceeded in this manner. First is the general appearance of the child, the vital signs, anthropometry, developmental assessment, head to toe examination, and calculation of the body surface area, and finally the systemic examination. Today we'll be talking about the all the points from the general appearance to the body surface area. The systemic examination, as told, will be dealt with when we see the examination separately. Each system separately.
Just get up. Okay. But you are seeing the PowerPoint now? Now?
Yes, sir.
Yes, sir. Yes, sir.
Yes, sir.
Okay. Carry on. Start.
So the sequence of examination as such, overall examination is like this: general appearance of the child, vital signs, anthropometry, developmental assessment, head to toe examination, body surface area, and then the systemic examination. We will deal with all of these up to body surface area because the systemic examination will be dealt with specifically in during each system examination.
So you are little louder. Loud.
So in general appearance, first of all, as the child is brought to you either in the emergency or in the OPD, or when you see the child for the first time in the ward, you have to note the general appearance of the child, the first and foremost. In the general appearance, you'll see the child's consciousness and the mental state. Consciousness is a person's awareness of self and the surrounding, and the relation of self with the surrounding. This is consciousness. Anything altered from the altered sensorium will vary according to the severity of the illness, and will proceed as like the first of all there will be delirium, and if it is worsening, little lethargy. Increasing lethargy is obtundation, and proceed to stupor and then coma. So you will level the conscious state of the consciousness of the child, and then we look at the mental state of the child. The consciousness grading has to be done in the general physical examination itself, and also it can be mentioned in the if there is any if the CNS is the primarily involved system, then you can mention it again in the central nervous system examination also. But this will come in your general physical examination also. And you have to do the Glasgow coma scaling if you feel there is an altered consciousness, altered mentation in the child. If the child is of normal mental status, is normally conscious oriented, you don't have to grade the GCS. There is the Glasgow coma scale was devised in 1974 by some scientists. It was meant for the adult, but in the pediatrics there is a modification which is used in the pediatrics, which is called pediatric Glasgow coma scale. Important for the undergraduates is to know the Glasgow coma scale. The pediatric Glasgow coma scale can can also be learned. But more important to know is the Glasgow Coma Scale, which can be even used in bigger children. And then you look at after seeing the consciousness and grading the consciousness into like a normally conscious child, or if the child is delirious, lethargic, obtunded, stupor coma, whatever the consciousness level of the child is. After grading that, you look at the child's mental state. The mental and emotional state can be, you can see the child is alert, happy, playful, which is a normal child. Or if the child is anxious, there is an anxiety disorder, or the child is unhappy to be in the hospital, is scared of seeing the doctor, the child is anxious, or if there is elation. Elation is like undue happiness, undue excitement. Is elation, is euphoric, is the child is having depression, the child is restless, dull, shy, timid, or obstinate. In children who have very overprotective parents, the children can be shy, timid, obstinate, not telling you the history, not telling their own problems by themselves. And then after seeing the mental state, you see the child's stature. The stature can be seen in the first impression itself. You can make out that the child is of thin build, is obese, is tall, is short. But then you have to specify the stature when you do the anthropometry. But by just having a look, first glance at the child, you can even see this child is a 5-year-old child, or a smaller child, or bigger child who is of the correct stature for his age, or is not of the correct stature, is malnourished or is overnourished. So that is the stature. And then decubitus. Decubitus is the posture of the child. Like the posture, if the child is sitting comfortably, or is assuming a posture of his comfort because he is in pain, or decubitus is the posture of the child. And other findings to be noted are like the breath and body odor. If there is any specific like metabolic disorder, you can smell the breath, and even the body odor can indicate certain illness. Like they can be acidotic breathing. You can have ketone, the smell of ketone in a child with diabetic ketoacidosis, etc. And you look at the cry and the voice of the child. If whether the cry is normal or is abnormal. Normally, it is said that the cry of a normal child is of a very loud, very lusty voice, very lusty cry, indicating you of something he wants, or something he's in discomfort or pain, or like that. So the cry, whether it is normal or abnormal, that also you have to see in the general appearance. And the voice also, it can tell you a lot of things. If the voice is normal, or if there is some abnormality, there is husky voice, the voice is there is a hoarseness in the voice, then also you have to mention it over here. And if the child is having some characteristic facies, which can be just seen in the first glance, even without having the complete head to toe examination, you can just look at the child's facies and then think about what this child, what condition this child might be having. So just elaborating the Glasgow Coma Scale, you all must be aware of this, must have read this already, but still just elaborating it again. The Glasgow Coma Scale has 3 components: the best eye response, the best verbal response, and the best motor response. Each of these give one points. There are 15 points in overall. The 3 points will have 15 points in total, and each of these will give 1 point for that level. And you sum up all the sum up the score for each of these 3 response, and then you see what is the total score, and then you comment upon what is the Glasgow Coma Scale of the child, which will indicate the consciousness level of the child. So just looking at it again, the best eye response is like this. In a normal child, the child is having spontaneous eye opening. It is giving a score of 4. If the child is not having a spontaneous eye opening, is lethargic, is lying down with a closed eye, but responds to you by a verbal command. If you tell the child to open his eyes, or look at you, and if the child opens its to verbal command, it is given a score of 3. And if the child does not respond to a verbal command, then the next thing you do is give the child a little pain, and if the child responds to pain, then it's given a score of 2. If there is no response even on calling or giving a stimulus of pain, it is given a score of 1. And the best verbal response, in a normal person, normal child, the child is oriented to his surroundings, oriented to time, place, person. It is given a score of 5. If the child is confused, it is given a score of 4. If the child is confused and giving speaking inappropriate words, like you're asking the child something, he's saying something else, it is not relevant to the question and to the situation, it is given a score of 3. If there is not even any word comprehensible to you, the child is making some sound, but it is not a proper word, it is just an incomprehensible sound, it is given a score of 2. But if the child is completely mute, there is no response, there is no verbal response, then it is given a score of 1. And the best motor response is the first normal child will obey to your command. You tell the child to do something and he's doing it, that is a normal child, that is given a score of 6. If the child is not obeying your command, but is able to localize a stimulus of pain, it is given a score of 5. If the child is not localizing from pain, like you give a stimulus in the hand and ask the child where it is paining, he's not responding, but then he's trying to withdraw from that site of pain, it is given a score of 4. And even worse than this, the child may not withdraw from pain, but if you're giving a pain stimulus, there is a flexion response, it is given a score of 4. And then if the response to pain is extension, it is given a score of 2. And if there is no response at all even to pain, it is given a score of 1. You sum up all of these, all the score that you get in each point, like the eye response, the verbal, and the motor response. The summing up, you come to a conclusion. What is the Glasgow Coma scale? The normal Glasgow Coma scale is supposed to be at least 14 or 15. The total score out of the 15 points is 15. You give 1 point each to each level, and it is given a score of the total score. If it is 15, then it is 15 or 14. It is normal. If it is not normal, then you grade it as unconsciousness, and the grading of unconsciousness can be mild, moderate, and severe. So the mild unconsciousness is a score of 12 to 13, and moderate is 9 to 11, and severe unconsciousness is a state of 3 to 8, and the state of 3 score of 3 gives you gives an indication that the child is in coma. That is, there is no eye opening, there is no verbal response, there is no motor response. That is a state of coma. Just giving a indication at this point. So this is a Glasgow Coma scale. After seeing the general appearance of the child, you note it down, and then you proceed to see the vital signs. Vital signs are the signs of life. There are 5 vital signs. Namely, initially there were 5, there were 4. Now they have recently added the saturation also. So there are 5 signs, vital signs, and they are the pulse, the respiratory rate, the blood pressure, the temperature, and saturation. Pulse is a waveform generated by the left ventricular systole, which traverses the arteries in the peripheral direction. So it has to be palpated in all the 4 limbs. Ideally, it has to be palpated in all the 4 limbs, and it should be palpated by the 3-finger method. You must be aware of the 3-finger method. You must have heard about it. But just to recapitulate, what is a 3-finger method of seeing the pulse? You use the 3 fingers, that is the index, the middle, and the ring finger. the finger which is closest to the heart, that is, if you see this, if you're seeing the patient's hand like this, palpating it, the finger closest to the heart, in my case, this is the index finger. It is used to control the flow of blood. That is, it is used to maintain a constant pulse pressure. The pulse pressure I'll explain in the coming few slides. And the distal finger, that is the ring finger in my case, is used to occlude the distal in the artery distally. Because suppose if you are palpating the radial artery, the radial and the ulnar artery are connected through the palmar arch. So the wave coming from the ulnar artery can also be transmitted towards the radial artery. So in order to prevent that waveform, you occlude the distal part of the, suppose the radial artery, you occlude it, and the middle finger is used to is the one which is actually used to assess the pulse. That is, whatever character or volume or whatever you are seeing, that is, the middle finger is the one which is used to assess it. So that is the 3-finger method of seeing the pulse, and the pulse has to be described in the following six headings. That is the rate, the rhythm, volume, character, if there is a radial or radiofemoral delay, and then finally you have to also comment on the condition of the vessel wall. The rate obviously is the number of heartbeat or the pulse per minute. That's counted. It has to be counted for at least 30 seconds to comment on the pulse. And the rhythm, the volume, character, all of these you have to comment. It is said that the pulse has to be description should be made of the pulse in different arteries. You have to make the assessment to describe the pulse. The rate, rhythm has to be seen in the radial artery ideally. The volume and character has to be commented upon in the carotid artery. The radial or radiofemoral, obviously in both the radial arteries or in the radial and the femoral artery, you have to cross check at the same time. And the condition of the vessel wall, it has to be checked in the radial artery. So the normal rate of the pulse rate varies at various age groups. So this is like just a table which is just indicating the normal pulse at various age groups. At less than 6 months, the normal pulse should be at least 120 to 160. At 6 to 12 months, it should be 110 to 120. At 1 to 5 years, it should be 95 to 110. And 6 to 12 years, it is 80 to 110. And beyond 12 years, it should achieve the adult target of pulse rate, which is 60 to 100 pulsations per minute. Okay, that was the rate, pediatric normal pediatric pulse rate in the pediatric age group. About the rhythm has to be commented upon if the rhythm is normal, that is the normal rhythm of the heart, or if there is an arrhythmia. If there is a bradycardia or a tachycardia, has to be commented upon in the rate. And in the rhythm, you have to comment upon if it is rhythmic or if it is not rhythmic. If it is not rhythmic, how is the rhythm of the pulse? If it is regular or irregular, and if it is irregular, how irregular is it? Is it irregularly irregular or is it regularly irregular? And the volume obviously has to be commented upon if it is a good volume pulse, a low volume pulse, or a high volume pulse. And the character of the pulse, like there are some characters which is like a slow rising pulse, a water hammer pulse, pulsus disferians, pulsus alternans. All of this has to be commented upon in the character of the pulse. And the radioradial, for the radioradial delay, you have to palpate both the radial arteries simultaneously. In a normal child, both the radial arteries will pulsate at the same time. If there's a delay, like you see in coarctation of aorta, then that you have to comment upon. And the radiofemoral delay also. Normally, the radial artery and the femoral artery pulsate at the same time. So there will not be a radiofemoral delay in a normal child. If there is a delay, then that you have to see by palpating radial and the femoral artery at the same time. There might be a delay in the femoral artery in a child who is a case of coarctation of aorta. And then the condition of the vessel wall is checked by just rolling the pulse on the hand over the bony prominence. It is in atherosclerosis, there will be hardening of the vessel wall, and the vessel will be felt very as a cord-like. There will be cord-like feeling in the vessel. And the next part of the vital sign is the respiratory rate. For seeing the respiratory rate, you have to count the rate for at least 1 minute. You have to look at the chest or the abdominal movement that moves with the respiration. You have to, ideally, you have to keep your watch and place it near the chest of the child or the abdomen of the child, wherever you are checking the respiration, the respiratory rate, and then count it for a complete 1 minute. You should. The idea of keeping the watch near the chest or the abdomen is to not lose 1 second of counting, because in a child having respiratory rate more than 60, 70, even 1 second count will be missed. If you look away from the abdomen or the chest to look at the watch. So ideally, you should keep the watch near the chest or the abdomen. Or if you have a timer, you can even use a timer. It has to be counted for one complete minute. Also, like pulse rate, respiratory rate also varies according to the age of the child. So the normal respiratory rate, according to the various age groups, are up to 2 months, it has to be at least 30 to 50 breaths per minute. At 2 to 12 months, it has to be 20 to 40 breaths per minute. At 12 months to 5 years, it has to be 20 to 30 breaths per minute. 5 to 10 years, 15 to 20. And more than 10 years, it has to be the normal adult respiratory respiratory rate, which is 15 to 18. And tachypnea is described for various age obviously, for various age group, the cutoff for breath to describe a breathing rate, a respiratory rate as tachypnea is different, like this. Up to 2 months, if the respiratory rate is more than 60, that is called tachypnea. From 2 to 12 months, more than 50 is tachypnea. From 12 months to 5 years, more than 40 breaths per minute is tachypnea. 5 to 10 years, beyond 5 years, if it is more than 30 breaths per minute, it is tachypnea. So just to look at a few causes of abnormal respiration. Tachypnea is described in the previous slide for the age group, the tachypnea. You see, if the child is having tachypnea, what all could be causes of tachypnea? Anxiety. If the child is anxious, if the child is scared of you, there's white coat anxiety, the child is anxious, the child can have tachypnea. Even if there is no other physical pulmonary or cardiovascular illness, the child might have tachypnea if he is anxious. And next is exertion. Obviously, during exertion, your basal metabolic rate increases, and there is tachypnea. And fever, hypoxia, acidosis, and pulmonary and cardiovascular conditions like pneumonia, pulmonary edema, all of these can lead to tachypnea. And some causes of bradypnea are alkalosis, hypothyroidism, increased intracranial tension. Hyperpnea is tachypnea and bradypnea, is like the excessive increase in the respiratory rate is called tachypnea, or excessive decrease in the respiratory rate is bradypnea. Hyperpnea is the excessively deep breathing, like deep breathing, excessive prolonged breathing is called hyperpnea. So hyperpnea can be seen in conditions like acidosis. It can even be hysterical. A child is just pretending, or it can be hysterical, and it is also seen in brainstem lesions. So the third vital sign is the blood pressure. Blood pressure, ideally, it has to be recorded in all the 4 limbs, especially if you are suspecting a cardiovascular illness. It has to be measured in all the 4 limbs. Important measure in the cuff size, in the blood pressure in children, is the cuff size. The cuff size has to be adequate for the child's size, the child's age. So to choose the right cuff size, you have to know how you have to measure the child's the cuff size you have to choose. The cuff size which has to be used for that particular child, first of all, you have to check the child's arm circumference. The cuff that you're using should be encircling the child's arm circumference by at least 80 to 100%. It should be either completely covering or at least 80% of the arm circumference is to be covered. And the length of the cuff should be covering the arm, at least 2/3 of the arm, or they say it should be at least coming up to the, 2 centimeters above the cubital fossa, where you'll be keeping your stethoscope and auscultating. So that is the cuff size that you have to choose for the child. There are various techniques for measuring blood pressure, which are the common ones are like the auscultatory method, palpatory method, flush method, oscillometry method, and Doppler method, which is obviously the hi-fi one. But the commonly used in the office practice or in the ward are auscultatory method and the palpatory method. The auscultatory method, obviously all of you know, is done by using a sphygmomanometer and your stethoscope. You place the stethoscope on the child's cubital fossa and auscultate on the brachial artery that is there. So in auscultatory method, what you do is, so first of all, to see this, you have to know the child's blood pressure, which is again varies according to the age of the child. So for that particular age of the child, you have to know the blood pressure, the normal blood pressure, and you have to inflate the cuff of the sphygmometer. It is 20 to 30 millimeter mercury above the normal SBP, the systolic blood pressure of the child, the expected systolic blood pressure of the child, and then you slowly release the sphygmomanometer pressure, and then you listen to the Korotkov sounds. The first Korotkov sound is indicative of the systolic blood pressure, and then you slowly keep lowering the pressure, the cuff pressure, till you start hearing the trailing of the sound, the Korotkov sound. The diastolic blood pressure is a time when the Korotkov sound starts to trail. Usually most of us tend to think that diastolic blood pressure is when the Korotkov sound totally disappears. That is not the diastolic blood pressure. The diastolic blood pressure is when the Korotkov sound has started to taper. That is the diastolic blood pressure. So this is the auscultatory method of taking the blood pressure, which is most commonly used. And then palpatory method can be used when you don't have a stethoscope, or when you're in a hurry, you don't have any stethoscope. You can use the palpatory method. By palpatory method, you can only obtain the systolic blood pressure. You cannot obtain the diastolic blood pressure. Again, for palpatory method, you use a sphygmomanometer, inflate the cuff till about 20 to 30 centimeter, 20 to 30 millimeter mercury above the normal systolic blood pressure of the child, and then you start releasing the cuff pressure, and then you palpate the radial artery, and then see when the pulse starts to reappear. That is the palpatory method of doing taking the blood pressure. In a hypertensive child, you can even do it if you expect that the systolic blood pressure of the child might be even 20 to 30 millimeter mercury even more than the normal blood pressure for the child. You can even inflate it beyond the time. The cuff can be even inflated beyond the time when the pulse disappears, and then again deflated till it reappears. So the time when it reappears is noted, and that is time and the pressure at which it reappears is the systolic blood pressure. And next is the flush method of taking blood pressure. The flush method is not a very commonly used technique. It is mostly used in a young infant, or even mostly in newborns it is used. So just to know how it is done, the flush method is done by first you elevate the child's limb, like you are using the upper limb, you elevate it, or even if you're taking the limb in the lower limb, you elevate the lower limb, and you let you elevate the limb, and then you tie the sphygmomanometer around the child's upper limb or the lower limb, wherever you're taking the blood pressure, and then you raise the again, like the palpatory method, like you are doing it, you again increase the cuff pressure till inflate the cuff till the child's limb completely flushes, is completely pale, like, till the blood till the pulse is occluded, increase the cuff pressure, and then when the limb becomes pale, then you slowly put the limb down and then slowly release the cuff pressure, and then you note the time when the limb starts flushing again, it becomes pink again. That is the time when that is the pressure you note at the time. That is the expected systolic blood pressure of the child. It is it is a little uncommon method of doing it, and a little cumbersome also. But just to let you know, the flush method of doing blood pressure. Oscillometry method is an invasive method where you use arterial intra-arterial catheterization you do, and then there is a monitor oscillometer machine, oscillometer which you connect, and then you see the blood pressure. It's an invasive method, mostly used in the ICUs, not commonly used in the office practice. And then the Doppler method, like all of us know, ultrasound Doppler method for checking the blood pressure. So that is the blood pressure. Just to let you know about a few formulae to calculate expected blood pressure in children. To calculate the 50th centile of systolic and diastolic blood pressure in children older than 1 year of age, the systolic blood pressure it is calculated as 90 plus age into, or 2 into 18 years. 90 plus 2 into 18 years will give you the expected systolic blood pressure, the 50th centile of systolic blood pressure for that child. And diastolic blood pressure is calculated as 55 plus 2 into 18 years. There is another method for calculating diastolic pressure, which is 60 plus 18 years. Just add the 18 years with 60. The lower limit of systolic blood pressure, beyond which the 5th centile, beyond which you say you become more aware of the hypotension that you have to treat, that is given as 70 plus 2 into 18 years. 70 plus 2 into 18 years will give you the lower limit of systolic blood pressure, beyond which you have to intervene for the hypotension. Normal blood pressure in children, again, it varies according to the age of the child. So this is the chart which just shows you how it varies. It keeps increasing from the newborn period to the age of 7 to 12 years, when it attains the adult normal systolic and the diastolic blood pressure. So it is important to know the age variation, because in a small child, if you see a BP more than 120 by 80, you call it hypertension. You not call it normal blood pressure like in adults. And in older children, if you see the blood pressure is low beyond the 5th centile as told in this formula, then you have to intervene again. So age-wise variation is very important to know the normal blood pressure. You have charts for this. Even you can use the charts. Just a briefing about the pulse pressure and the mean arterial pressure. The pulse pressure is the difference between the systolic and the diastolic blood pressure. This normal range is 30 to 60 millimeter mercury. It is important because you might have a normal systolic or a normal diastolic blood pressure, but in some conditions, but the pulse pressure might be varying and will indicate you the disease, the illness that the child might be having. So some conditions in which you see a narrow pulse pressure are the aortic stenosis, mitral stenosis. The wide pulse pressure will be seen in conditions like patent ductus arteriosus, aortic regurgitation, and aortic regurgitation. And mean arterial pressure is the product of the cardiac output and total peripheral resistance. Normal mean arterial pressure is around 100 millimeter mercury. The formula to calculate the mean arterial pressure is diastolic blood pressure plus 1/3 of the pulse pressure, or it can even be calculated as 1/3 of diastolic blood pressure plus 2/3 of systolic blood pressure. The fourth vital is the temperature. The temperature can be measured in various sites in the body. Wherever you are measuring the temperature, the thermometer has to be kept there for at least 3 to 5 minutes. The sites where you can measure the temperature are the oral cavity, the axilla, rectum, groin. Groin, that is the area in between the thigh and the abdomen, you can keep the thermometer. That is the groin. In the ear canal, you can measure the tympanic membrane temperature. And even the skin over the forehead, you can measure the temperature. Normally, the rectal temperature is more than the oral temperature by 1 degree Celsius, and oral temperature, oral cavity temperature is more than the axillary temperature by more than 1 degree Celsius. Factors affecting temperature are obviously, as all of us know, infections. Infections can lead to fever, which will be causing an increase in temperature, or infection which is leading to shock, which can lead to hypothermia. And metabolic rate, a child who is having a high metabolic rate will have a higher temperature, and a child with lower metabolic rate will have a lower temperature. Endocrine abnormalities, and even the circadian rhythm. It is saying in the early morning, your temperature is, body temperature is at the lowest for the whole day. So even the circadian rhythm can affect your body temperature. So temperature normal range is in degrees Celsius, it is 36.6 to 37.2. Fahrenheit is taken as 98 to 99. Subnormal temperature, that is cold stress, is a temperature of less than 36.6 degrees Celsius, or a temperature less than 98 degree Fahrenheit. Hypothermia is described when the temperature is less than 35 degrees Celsius or less than 95 Fahrenheit. A child is said to be having fever or is febrile when the temperature is more than 37.2 or more than 99 Fahrenheit. Hyperpyrexia is a condition when the temperature is way beyond the fever range, which is 41.6 degrees Celsius or more than 100 Fahrenheit. So the fifth vital is oxygen saturation, also called as SpO2. It is a measure of the amount of oxygen carrying hemoglobin in the blood relative to the amount of hemoglobin not carrying oxygen. So from the percentage, from the 100% of hemoglobin that you have, how much percentage of it is carrying oxygen is the SpO2. Suppose you're saying the SpO2 is 100%, so the 100% of the hemoglobin in the blood is carrying oxygen. SpO2 is the peripheral capillary oxygen saturation. Pulse oximetry is a non-invasive method for monitoring oxygen saturation. Normally, oxygen saturation, normally in invasive ICUs, we use the arterial blood gas, but pulse oximetry is a method where you can do it by non-invasive method. And you have various saturation probes you can use for pulse oximeter. Normally, the oxygen saturation should be 94 to 100%. It need not be 100% all the time. Even 94 to 100%, this range is a normal range for oxygen saturation. So after completing the vitals, you come to anthropometry. Anthropometry is the measurement of the body. So various parameters that you use for measuring the body are the weight, the length. Length is used if the child is less than 2 years or if the child is bedridden. You take the height if the child is more than 2 years, is not bedridden, is able to stand up. You take the height of the child. Then you take the head circumference, the chest circumference, the mid-arm circumference. Mid-arm circumference is supposed to be constant between the age of 6 months to 5 years. So mid-arm circumference is a parameter also to describe severe acute malnutrition. So mid-arm circumference you take, and then you take the upper segment to lower segment ratio, and finally the arm span. So anthropometry just doesn't end here by taking the weight or the length. You also have to take the weight of the child compare it according to weight for height or weight for length, and weight for the age of the child, or length or height of the age for the age of the child. You have to compare. And then there are various charts. There are IAP charts, WHO charts, where you have to plot the various parameters. That is the weight for age, the length for age, or the weight for height that you have to see. Then you have to come to interpret this.
Pepu,
Yes, sir.
you can skip the anthropometry. We will take one day full class. Okay.
So anthropometry we will elaborate in a class separately. So this is just overall. You have to do the anthropometry of vitals. And next comes the developmental assessment. Developmental assessment is not required to be done in all the children, but in children who you are suspecting is having a developmental delay, or child who is having a central nervous system involvement, then you have to do a developmental assessment. Development is already told to you by sir, and which also will be elaborated in a developmental history. From there you can see how the development of the child you can now apply it, you can now assess it in the developmental assessment. You have to have a whole kit to perform a developmental assessment. development of a child is said to be closely associated with the maturation of the central nervous system. So obviously, as a child grows up, as a child matures, the central nervous system matures, and the functions of the child become more refined, and the development keeps changing according to the age of the child. So developmental assessment has to be done according to the age of expected for that age of the child, and if there is a involvement in the particular area, like in the motor or in the social or whatever, you have to focus more on that. And after doing the developmental assessment, comes the head-to-toe examination. Head-to-toe examination has to be done in all the cases. Like even if you're suspecting, even if you think a child is a case of pneumonia, or a child is a case of loose stool, meningitis, like some minor illness or severe illness, it has to be done. You should not miss a single pointer to any other illness besides what the mother is telling you. So the head-to-toe examination has to be done in all the cases, in all the children who are presenting to you. It is more significant, but it's more significant in the presence of a child who is having dysmorphic facies, in a child with severe nutritional deficiencies, to look for signs of nutritional deficiencies, particular nutritional deficiencies, which will manifest in your skin, your hair, or like edema. You have to do the head-to-toe examination in children with nutritional deficiencies. And it's also significant in children with chromosomal anomalies, and also in hormonal disturbances, like a child with precocious puberty, a child is having PCOS, like polycystic ovarian syndrome, like hormonal disturbances. So head-to-toe examination, you have to focus more on that area of involvement. The sequence, obviously, head-to-toe means up to down. So skull, first of all, skull. In the skull, you have to note the shape, the size. If the skull is like there is a macrocephaly, like after seeing the anthropometry, you'll know the chart. You'll know the normal head circumference of the child. So if you see the size of the skull, you see if there's a macrocephaly or if there's a microcephaly, and then you have to see the shape of the skull. Normal shape, or if there is some abnormal shape, like some described shapes like brachycephaly, oxycephaly, dolichocephaly. So shape of the skull, and then look at the fontanelles. Fontanelles, there are usually there are 4 fontanelles that you have to mostly focus on: the anterior fontanelle, the posterior fontanelle, 2 lateral fontanelles, that is the sphenoidal fontanelles just in the temporal area, and then 2 mastoidal fontanelles just behind in the mastoid area. These are the 6 fontanelles, like 4 headings, the fontanelles that you have to check. And then the fontanelles, they're present, fontanelles are like they're present, or they're closed, or the fontanelles are like abnormally large, they are abnormally tight or pulsatile, that you have to check in the fontanelles. And then in the skull, you have to even check the sutures. The sutures are closed, they're open, or they are overriding. The sutures you have to check. And then the molding, obviously in a newborn, or in a, you have to see the molding. And if there's a cranial bossing, abnormal craniotabes, abnormal head movements. Craniotabes, just to elaborate again, craniotabes is also called as ping pong ball cranium, which is in which the cranium has become soft because of some illness. Like it is seen normally ping pong. The ping pong feeling of a skull, that is when you compress a skull, that is it just gives a soft give way feeling will be there. Not give way, a soft depressing feeling will be, depression we can do. That is is a ping pong skull. It can be normally present in children up to even 3 months of age, newborn to 3 months of age. But in all the children, it is abnormal. The craniotabes is abnormal. Can be seen in cases of hydrocephalus, in children with rickets, can be there. So craniotabes and abnormal head movements, like if there is a titubation, side-to-side movement of the head. So that abnormal head movements you can see, and some tests that you perform on the skull that you can do at this stage of examination. just to name some tests, which is like the MEC event test, the trans-illumination test. The MEC event test is done by tapping on the, percussing on the skull, and then listening closely. There is a crackpot sound that if it is present, it is abnormal. This is a positive MEC event test. It can be seen in children with hydrocephalus. And trans-illumination test is also like in any other trans-illumination test that you do. It is done by using a torch, which has to be rolled inside either a cardboard or inside not a cardboard, but inside a carton or inside a paper, or ideally should be wrapped inside a tube, rubber tube, and then the torch should be placed on the skull. And normal trans-illumination should be present only up to 2 to 2.5 centimeter beyond the site of the placement of the torch. If it is beyond that, that is a positive trans-illumination test. It is can be positive. It can be present in cases of hydrocephalus, where there is excessive fluid accumulation inside the cranium. That is the skull, and then after checking the skull, you see the eyes. They look at the eyes for the spacing. If there is hypotaylorism, there's excessive spacing between the two eyes. You look at the palpebral fissure, the horizontal fissure, the vertical fissure. If it is abnormally wide or narrow, palpebral fissures you have to be seen. And the eyes, you have to also see the eyebrows, the eyelids. If there is any disease, infection, missing eyelashes, abnormal color of the eyelash, abnormal color of the eyebrows, that you have to see, and then see the conjunctiva, the bulbar conjunctiva, the palpebral conjunctiva, and then the cornea. You have to see the pupils. You have to see abnormal size or shape of the pupils, and then you see the iris, the color. If there is abnormal color, heterochromia that you can see. And also in the eyes, you can also see some nystagmus. You have to see. Nystagmus is like the abnormal jerky movement of the eyes, which can be described in various types, like the horizontal nystagmus, vertical nystagmus, jerky nystagmus, pendular nystagmus, like various nystagmus that you can note in the eyes. And then after seeing the eyes, you proceed. You see, obviously, coming to the nose. You look at the nose. If there is an abnormal shape, abnormal size, the placement of the nose, and in the eyes, you also see if there is some epicanthic fold. In children with Down syndrome, you can see an abnormal epicanthic fold that is there. Okay, and in the nose, the outer appearance, the skin, the shape, the size, the nose symmetry. If there is any nasal deviation inside the nose, if you can see any mass, any polyp, or any infection, any abnormal discharge from the nose, that you have to see in the nose. And then ears, also you have to start from the outside to the inside. That is, you have to first check the pinna, if both the ears are present or not. If both the ears are of normal shape, size, they're symmetrical, placed at the same location, or like it's below, or low set ears, that you have to see in the ears. And then you have to look at the pinna, the external ear auditory canal, you have to see, and then the tympanic membrane. And mouth, the oral cavity has to be seen. The lips has to be seen. If there is a cleft, palate, or cleft lip or palate, or that you have to see. A partial or a complete palate, that you have to note. The tongue has to be noted for abnormal color, or the size of the tongue, that has to be noted. And the teeth, the dental hygiene has to be commented upon at this point. Then the throat comes. Then inside the mouth comes the throat. For the throat, you have to look at the tonsillar fosses, the uvula, if it's midline, it is deviated, and then the tonsils has to be noted if it is normal, if the tonsils are present or absent, or if there is any congestion, enlargement, discharge from the tonsils. And then the posterior, the pharynx has to be noted. And then after the throat, you have to look at the neck. The neck, obviously, the shape, the size. If there is any swelling on one side or both the sides, the neck has to be examined for that. And the chest and the thorax, obviously the outer appearance. The examination of the chest has to be elaborated in the respiratory examination also. But out here you can look at the chest shape, symmetry, if the chest movement that you can see at this point also. If there's any external scar or anything, and then not to miss the genitalia. Genitalia also has to be examined. The child should be completely exposed for this purpose, because sometimes you might miss an scar, an insect bite, or something somewhere around the groin area. So around that area also has to be exposed. The genitalia has to be noted. The genitalia, their normal shape, size, the testes, they are distended or not. If there is an ambiguous genitalia, that has to be noted. Any infection, discharge, genitalia has to be examined, and then followed by rectal examination. Rectal examination not to be done in all the children, but you have to know which children has to undergo rectal examination. And for children who require a proper rectal examination, should not be missed. And after that comes the extremities. In the extremities, you look at the upper limb, the lower limb, like the limbs are present or not. There is a pocomilia, amilia, the absence of limbs, absence of some fingers, that has to be noted. And in the extremities also you look for some signs like the clubbing. The clubbing, as all of us know, is the enlargement of the soft tissue near the distal phalanx. Grading of the clubbing is done, and clubbing is said to be present in children who have the Lowy bones angle obliterated. The angle between the nail and the finger, the skin is there is in normal people there is an angle which is called the Lowy bone angle. If it is obliterated, there is clubbing. It is grade 2 clubbing. It is called a positive Shamrod sign. So clubbing also has to be looked for, and the grading has to be done. If it is grade 1, 2, 3, 4, grading has to be done, and that is for the extremities. And then comes the skin. The skin from the top to bottom, from the head to toe, you have to look at the skin color, the skin. There's abnormal pigmentation. There's some some abnormal skin signs like Ashleaf macules. The skin has to be noted for some signs of some neurocutaneous markers, or some disease presentation also can be manifested in the skin. Also, skin has to be noted for the presence of pallor, icterus cyanosis, like all of us do with the pallor icterus cyanosis. Pallor can be seen in the palpebral fissure and in the skin of the palm. It can be noted, and icterus also has to be noted in the skin. Icterus in the newborn first appears on the forehead skin, as they say, forehead skin, and then the bulbar conjunctiva, and then it progresses from the cranial to the craniocaudal direction. So icterus has to be noted in the skin. And then presence of cyanosis. It's abnormal bluish discoloration of the skin. Cyanosis can be seen and noted if it is just peripheral, that is in the extremities, or central cyanosis, which can be seen involving the lips, the tongue. There is a central cyanosis. And then also not to miss edema. Edema, if it is present, where is it present? On the face, the periorbital edema, and the limbs, the lower limbs. If it is edema, if it is present, if it is pitting or not pitting, that has to be noted. And or edema, if it is present in all over the body, it is called anasarca. And then you have to look at the nails, the hair, for abnormal shape, abnormal pigmentation, abnormal distortion of the nail. Has to be noted. And then finally, lymph nodes has to be palpated. That is from the lymph node groups. You have to know well or where all lymph nodes are present in the periphery, which is accessible to you, and we have to look at all the lymph node groups. The cervical lymph nodes, if they are there, palpable, enlarged, the size has to be noted, and then the lymph nodes, if there is a single lymph node involvement, multiple lymph node involvement, multiple sites of lymph node involvement, the axillary, the inguinal, the cervical, and the size. And if there is a matting of the lymph nodes, that is, they are all bound together. There's a matting as seen in TB lymphadenopathy. If there is a lymph node tenderness is there, or non-tender lymph node, all of this has to be noted in the lymph node examination. Uh, so all of this will, so till here it will complete your head to toe examination. And after that, finally, you have to see the body surface area. The body surface area has to be, is sometimes considered as a part of the anthropometry also, but then separately also you can comment upon the body surface area. Body surface area is important because some drugs that you administer to the child in some disease conditions are noted in given according to the body surface area. So body surface area that you can calculate. The most common use formula for calculating body surface area is the Mosteller formula. For this, you obviously need the weight and the height of the child. In this, you'll get the body surface area in meters square. The formula is like this: the whole under root of weight in kg into height divided by under root of 3600. This will give you the body surface area of the child. Another simple formula for, there are various other formulas, but I think this formula is adequate for undergrads, easy to remember. And another simple formula for weight can be for children between 3 to 30 kilograms of expected weight. You can calculate it like this: weight in kg plus 4 divided by 30. This will give you the body surface area. So these two formulas for calculation of body surface area can remember. So that is all for the general physical examination. So hopefully till the general physical exam, from the history, till the general physical examination, you would have come to note the major system involved and then focus on this, the main system involved later on. And the systemic examination will be dealt separately, specifically in various other classes. So that is all for the general physical examination.
Just come together. No? So thank you, Pepu, for your excellent deliberation, exhaustive. Okay, so probably history taking and general examination, you do it properly in a systemic order, you can 99% of the illness can be diagnosed. Only to confirm your suspicion, you have to do certain tests or systemic examination. Now you all know this history and temperature checking, they are diagnosing COVID-19. Okay, thermal screening of cold, okay, COVID, okay, quarantine. So like that, simple thing. I think just feel the pulse, you know the diagnosis. Like absent pulse, you may think it is coarctation or arrhythmias, I mean some irregular pulse, or there is clotting pulse, you can diagnose PDA or aortic regurgitation. Okay, some icterus, you know, general examination, then you know the diagnosis. Probably there are so many causes of icterus. Just see the hands, there is a clubbing, there is only selected few conditions you can think of. Okay. So, but don't worry. She was telling so much about general examination. Just go through, I have already shared with you some books. Okay, just go through some guidelines. Don't worry about it. Okay, even after 40 years, I am still learning. Okay, so it is, it's not going to, oh, I use so much. Don't worry about it at all. You can learn everything here. Okay, once you have come here. So some of the mnemonics also you can learn. Okay, but don't write it in the exam. Pickle, no pickle. No? What is pickle? Anybody knows? I have unmuted all.
Yes, sir, we know.
What is that pickle?
Sir, P for pain. Sorry, P for sorry. P for Peller, sorry. P for Peller.
Peller.
I for Icterus. C for Cyanosis.
Cyanosis, troubling lymphadenopathy and edema.
Okay, you have done it. Okay. So, some simple thing you can remember. So, on examination, child conscious, alert, same thing you can repeat it and you can practice it in your this one also. Okay. You know, day to day. Now, what is normal you should know. Okay, don't worry about the abnormal thing. Just put your step to your father or mother or brother or sister, whatever may be. Just listen to the heart sound, count the heart rate or pulse rate, do capillary refill time. I will another day I will demonstrate what is capillary refill time and other thing. So one day, full day, I think 1/2 an hour we need to take dietetic history. It is most important for you. Another day we will take about the immunization schedule. I will try to go to the immunization clinic. From there, I wanted to show you. And another day, developmental history. That's also most important thing. Slowly we can go. Just spend half an hour today. Okay, just half an hour every day for pediatrics. Okay, today you have learned history taking. Just open the book. I have already shared the IAP textbook of pediatrics. Just open the book. What is it going on? Okay. If you have some doubt, we are always here to clear your doubt. Okay. Always your Google doctor is there. You can clear. Okay. So, and just general examination. You will have lot of pictures. She was talking about ping pong, this one, and Mercivan sign, crackpot sign. Just go and see what is crackpot sign. Okay. All these things you can learn yourself. Okay. Then next Saturday we will have 1 or 2 classes. Okay. So is there any other doubt from you? Doubts? I can clear you or Dr. Huh? No, unmuted. They have to unmute. No, this is unmuted. No doubt.
No, sir.
Okay, then I will ask one doubt. Okay, one question. What is the normal heart rate of a newborn? She showed a heart rate now. What is Simran? Who is this Simran? About Julian Marpom. What is the normal heart rate? Okay, anyway.
Around 110 per minute.
Okay, it is newborn, it is fast as they become, as we grow, it is becoming less. Like that respiratory rate also, it will come down. Okay. It is 120 to 140 in newborn, up to 160 it can go. Oh, it's okay. So, like normal thing you have to learn. Just count the respiratory rate, you can diagnose pneumonia in children. Okay. I will try to upload it in YouTube also. Okay. When you come here, we can have some more on hands-on training. Thank you. Thank you. Bye. Bye.
Thank you, sir.
Thank you, sir.
Thank you, sir.